Hello everyone, I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I'm delighted to welcome you to today's webinar. If you don't know the PCC, we're a national organization that brings together leading voices from across the entire healthcare landscape. And these individuals and organizations are committed to improving the nation's health by strengthening primary care. Our discussion today is focused on proposed changes in the 2027 Medicare Part B payment rule and implications for primary care clinicians and beneficiaries. A few housekeeping rules before we get started. First, I want to remind folks that we are in the middle of conducting a field survey of the primary care community, asking for your feedback on the advanced primary care management codes. If you have a moment at the end of the webinar, we'd love for you to fill out this survey. Our team will drop the link in the chat right now, but you'll also get it at the end of the webinar. This session, like all of our webinars, is being recorded and it will be posted on our website, the PCC, within 48 hours. You can find all of our previous webinars on that site. We'll be taking questions versus Zoom Q&A tool, which is usually at the bottom of your screen. Both Dr. Jake Quinton and our three incredible panelists will be fielding questions during the Q&A sessions. Feel free to drop those questions in at any time. Chat's been disabled for viewers, but our team will provide links to a lot of relevant resources, so look out for those. We're really committed to delivering high-quality webinars, so we'd love for you to fill out the survey at the end. We get lots of great input, both on what you thought of the webinar, but also on future webinars. Now, let me introduce our first guest. Many of you know him well. He's a real leader in the field, Dr. Jake Quinton. Jake currently serves as Chief Medical Officer for Medicare Parts A and B, and he's been and part of the Center for Medicare Leadership team in the front office, working to align spending and value for 30 million original Medicare beneficiaries. Welcome, Jake. He's also a primary care internist, and that's really important here. He not only develops policy, but he knows what it's like at the sharp end of care. And he leads the Center for Medicare's work in the physician fee schedule, which is the focus of our conversation. But he also works on ACO policy, which is also included in the Medicare physician fee schedule, and serious illness and palliative care. He joined CMS 5 years ago and has built out alternative payment models in primary care, led improvements in quality measurement, and also maintains a clinical practice at an FQHC in suburban Maryland. We're thrilled to have you with us today, and you're going to help us break down this massive and really important rule. So welcome. Let me start us off by asking you to just, it's a long, complicated rule, Jake. If you could distill the primary care part of the rule into a few key sentences to give us a sense of where does CMS hope to take key primary care objectives this year and in the years ahead.
Thanks so much, Ann, and great to be back with the PCC. I think it was just yesterday that we were here talking through the finalization of last year's policies and the efficiency adjustment, and we're back this year with a proposed rule that we think is also transformed for improving primary care. In this year's rule, we actually had so many requests for information. We've even incorporated a strategy blog, which we published concurrently with the PFS and the OPPS. So more to say about sort of how the strategy all fits together. But when we think about primary care, we're ensuring that it's part of our broader strategy to align spending and value. And so we recognize that there have been payment distortions that have crept into the fee schedules, and those have sometimes led to overvaluation of services and sometimes led to undervaluation. And so we know that primary care has been historically undervalued in the physician fee schedule, and we're embarking on a 2-year strategy to change that. The first thing I want to say about the proposals this year, we believe strongly in accountable care in this administration, and we believe that the original Medicare can transform more and more towards accountable care organizations. So as I think 75% of physicians currently that are primary care docs like myself are in an ACO, we want to encourage more and more to join. And we've got some transformative policies to help that along. The second thing to say is that we're not in alone at the Center for Medicare. The Innovation Center has established a series of alternative payment models for accountable care organizations over the last decade, and we really need to learn from them and learn what's working and incorporate what we can from those CMI models. And you've seen some policies to help with that. And the third thing to say is our work's aligned to what's happening with HHS more broadly. We have a secretary that's dedicated to making America healthy again, and we want to incorporate evidence-based lifestyle change as part of that initiative. So 3 quick examples for what that looks like. The first is to say, for the very first time in the physician fee schedule, we're recognizing that the resource costs associated with caring for patients in an accountable care relationship is different than typical fee schedule primary care. And so we think that we need to recognize that difference, and we're proposing stratifying G2211. That's our code for complexity of care, acknowledging the importance of serving as that kind of focal point or primary care quarterback, as we all do. And we think that the time and resource associated with doing that is so distinct that we're actually planning on paying twice as much in an accountable care organization as outside of it. We're calling it Mod 1 and Mod 2, which is maybe not the best moniker, but it's really important. It's the first time we've ever considered changing payment for the underlying fee schedule service based on whether you're in an ACO or not. Second thing to say in terms of what we're learning from the accountable care models from CMMI, ACO REACH demonstrated that they could establish prospective primary care payment and do so effectively. It's also part of the lead model that's coming in soon. And we wanted to learn about that as part of one of our multiple requests for information in the fee schedule this year. We say in the fee schedule we're actually requesting information this year, and as soon as possible plan to implement a prospective primary care payment for shared savings. And we hope that that's going to happen next year, but we'll see. The only other thing to mention in terms of what we're learning from CMMI, they've been establishing cost sharing reduction waivers in their accountable care organizations. And so if ACO REACH is able to establish a mechanism by which you can reduce cost sharing for Part B services, it's a long-standing primary care goal. And so we're proposing doing that this year in the shared savings program. So really exciting stuff that's coming from the Innovation Center, and we understand that there's the requirement for certification expansion, but we can take those good ideas and bring them and scale them into the permanent program as we find evidence they're working. I will say when it comes to MAHA, there's some important services that we're considering this year. First, we think that if you want to establish evidence-based lifestyle change recommendations, it can be done in groups. And so we're establishing group visits for the first time and considering it's resolving a gray area in coding and payment policy, but we really think the lifestyle medicine community and the functional medicine community have shown us enough evidence that their care delivery models really require these services. And that's not, I should have said at the top, we've got about a 20% increase for some behavioral health services as well. So things like the collaborative care model, the screening for behavioral health and referral to intervention, like smoking cessation services, those are all big winners in this year's fee schedule. And so it's not just primary care, but we know it needs to be integrated with behavioral health.
Well, whew, okay. Jake just summarized a lot of the primary care provisions that we have identified as really important to primary care. And I think we're going to try to dig in on a number of them. But as you can see, they really span the waterfront, and there's a lot of different dimensions here. But I will also say that it's not, you're proposing things that are not only good for primary care clinicians, but also for beneficiaries. And I think that's really important. You mentioned this, but I just want to underscore this. We've been sounding the alarm for some time now that we've had a systemic undervaluation of primary care and behavioral health. And this has huge implications for the kind of care that people receive. Because we do incent a whole set of services that are downstream, acute and specialty services, and we undervalue the kinds of services that primary care provides. And I will say that I think that you all have been unafraid to rethink, how we price, and it is absolutely critical because even in value-based models, the guts are always about the prices. So it's really important. So tell me in a little more detail, how are you thinking about addressing the mispricing that currently exists in the fee schedule? And that informs whether you're under fee-for-service or in value-based arrangements.
It's a great question and a big question, one that keeps us up at night. And so we've got a number of approaches by which we want to address what we'll describe as the pricing distortions or how we're aligning spending and value. And in particular, we continue to be interested in individuals and groups submitting data to help us set these prices. We think that as federal rate setters that we can learn from the markets and help understand how to set prices better. So it's a continued call for information if the individuals want to submit actual empiric data to help us set prices. I'll give one example from our home state of Maryland. So the all-payer claims database in Maryland had individuals that lead it had done an analysis to identify that amongst a specific code that's a tissue exam for pathologists, something that we don't think is happening too frequently. More than 500 times in our home state of Maryland, that service was conducted so frequently and billed for so frequently that the actual time that was estimated to be spent was more than the 24 hours in a day. And so we know that these examples exist, and deep in the fee schedule, in the potentially misvalued services, we're asking for comment on potentially how to take action there. So we want you to submit data to help us set prices. We think it's incredibly important. And in terms of where we're going over the next year or two for primary care, there's the transformative work in G2211, but then and all the great ACO work. But we're, I think, about a 30-page request for information on the overall reimagining for primary care evaluation. And that's soup to nuts. That's from the evaluation management visits to the care management code services, rethinking like what would it mean to incorporate technology into primary care. And this is one of the more substantive requests for information in this really broad fee schedule, because we want to take a really hard look at revaluing primary care appropriately as part of the Secretary's agenda.
Well, that's big, a 30-page RFI. Okay, I confess I have not yet read that, but you know, it warrants that kind of detail because this is a really complex area, and I think that we all want there to be change, but we also recognize that we have to go about this in a way that is drawing upon empiric data, being very careful about how we evolve this. But things need to change, and we're excited that you all recognize that, and we look forward to partnering with you and others in our community to help inform your work going forward. You know, the rule really does focus a lot on how can we get more beneficiaries into accountable care arrangements. And we know that ACOs that are primary care centric generate 2.5+ times the savings as others. So for an independent practice, new to, let's say, an ACO like the Medicare Shared Savings Program, if this rule gets implemented, what might they face in the coming year, and what would their future look like?
Absolutely. Thank you so much for that question. I think well, let's just be honest. The headlines we're hearing are that there's another cut to physician services. And so we recognize we work within the constraints that Congress established for us. There was a 2.5% statutory increase last year that expired. Absent that, there would be a conversion factor increase, but we know it came down about 1%. For those clinicians that are working to care for the communities in the primary care setting, we acknowledge that you may not have the resources, the technology, the capital investment to start an accountable care organization, or the legal support. And so we're dedicated to making it more straightforward. We want to simplify what it means to start an ACO, to participate in one. We're looking to actively deburden the quality measurement process.
Deburden, that's a new verb. We're all for deburdening.
Yeah, so deburdening primary care at large. So in so many ways, we know that if an ACO is a constellation of primary care practices, they may be on a different EMR, and we just need to think through what data do we really need back to understand the quality of care. How should we be thinking about some of the specifics? And And so on a quality front, we know that that's a big barrier for folks, and so we're actively working to simplify or deburden that process. We're also thinking hard about the specific proposals. So yes, there's a overall 1% conversion factor decrease. If you do the tally of what that additional G2211 change would be, if you we're proposing transitioning it from a flat visit fee to a proportion of every 99213, 4, or 5. And so 16% if you're outside of an ACO, 32% if you're inside of an ACO, and we think that that's a pretty substantive increase directly to the primary care clinician.
And what about in terms of administrative burden? What's the difference between an add-on code versus a modifier?
It's a great question, and some of the actual, on a contracting basis, some of the actual RVUs, we need to make sure that they're consistent. But what it means more than anything is that for patients that are receiving primary care services, they're trying to call and ask what exactly is a G2211 service. I went to the doctor. I understand that I know what happened at the doctor's visit, but what's this other thing? And so we're trying to resolve that tension. And so it should be a single claim line. Should allow it to be more understandable to patients principally.
Got it. Got it. And is it also easier for the primary care clinician?
Oh, sure. I mean, so yes, I live in the physician fee schedule. I love its idiosyncrasies. I love all the pieces. As a practicing clinician, the simpler the better when it comes from a coding perspective. So a new code to memorize and work with is always going to be more challenging as an add-on code than a modifier on the typical claim.
Right, and it's got to get then into your system, program into your system, and you've got to then bill it and all of that. Okay, so we like this idea of easier. We like this notion of additional support if you're in an ACO. We do recognize that because of the budget neutrality constraint, there is a bit of a haircut. Maybe Congress will address that. We'll see. But in terms of the structural things, you guys are really trying to make some changes to support this longitudinal relationship through the G2211. And I think that's really important. We think that's the heart of primary care. And so we're all for that. We're also excited to see that you are thinking about how do we deliver more holistic care. Yes, the medical issues that beneficiaries present with, but there's a lot of other things related to behavioral health, lifestyle, and the like. And so, we advocated for, and so did many of our members and those across our community, and we're pleased that we see health coaching support. That was a code, but it didn't have a remuneration. Now it does. Shared medical appointments. I think that can also be a benefit for beneficiaries to be in community, and with a similar set of health issues, and learning from their peers about how they are managing. And then more enhancements for behavioral health, which, just like primary care, has been systematically undervalued. But if there's one whole health strategy that you think will really lower mortality, incent more prevention, help lessen the hospital and ER visits, it really is the continuity of primary care. And that's what the Advanced Primary Care Management Code aims to support. We share some of the concerns you have, that there's been some, the uptake has not been as robust as we'd like. And some of that we hear from, you heard we're doing this survey, but also just informally, and we're doing our evidence report this year on APCM, relates to the beneficiary cost sharing. So how do we address that?
Absolutely. So much to say there, and really appreciate the comments with regard to the holistic nature of some of these services. And I'm very excited about health coaching, and we think that health coaching visits will really incent the lifestyle change that we know is going to be required to make help our patients stay healthy. when it comes to APCM, you'll notice that we didn't make specific proposals this year, and we spent the time to not address low-hanging fruit, but we acknowledge that there's been, since about 2019, the shared savings program has been on one course, and we're really trying to establish a growth trajectory for the shared savings program. And so the reason the care management services APCM included was part of that request for information is we wanted to spend the first year working on our ACO policy, establishing that pathway. And candidly, because of the way that lawyers that are much smarter than myself have established the consolidated safe harbors, that is really the best first way to get at cost sharing. We're not saying that cost sharing in the underlying fee schedule is impossible, it's just a much higher barrier. And so when patients are in that value-based care arrangement, we have the opportunity to establish these cost sharing reduction waivers faster. So when it comes to APCM and other services, there is the possibility, certainly in future work, to address cost sharing there. I'm most optimistic about being able to do it within an ACO, and so that's part of why we're so excited about growing those programs. And then when it comes to APCM's uptake, we know cost sharing is part of it. We know just we have a long list of services that can be included in advanced primary care management. We've been very clear that we're not specifying they all need to be included every single month. And I think there's just enough ambiguity in that service that it makes it challenging for systems to turn on and off. We have, outstanding primary care leaders like Bob Phillips is telling me that at his system, that Inova just won't allow them to pay for it because they're confused. And if folks like that are struggling to have this code turned on in their system, we need to do more to provide clarification. And we're going to be requesting a lot of information about how to reconsider not just APCM, but the other care management codes, because we've seen that their initial intent, which is to provide between visit care and this glide path to a prospective primary care payment, hasn't really been realized in the way we expected. Now, we're working within the statutory constraints we're given by Congress, we're working within the fee schedule constraints we have, and there's a storied history throughout the Federal Register on how these care management codes have been developed, but part of what we're asking questions about is how to rethink that in what's going to help patients more.
Super. So if I could just recap, I heard a couple of things. One is you're seeking to give ACOs the opportunity to waive the beneficiary copay in ACOs, and that's sort of like according to the lawyers, the easiest way to proceed given your authorities. Maybe down the road that would happen either through CMS or perhaps through legislation. But I think what I'm hearing is recognizing the importance of not having a financial barrier for beneficiaries to get primary care, to get behavioral health. You know, that is something that we want to make sure that the front door of the healthcare system is open to everyone. And when you've got a financial barrier, there's going to be some folks who can't go through that door. So we applaud that, and we want to encourage you to go in that direction. I think what I also heard is sort of the excitement about really, building this out further into the future, and so moving more toward prospective payment, building on the APCM. So that's really very, very important. There's a lot here in the fee schedule, as you can see, and now I think we are ready to open it up for some questions from the over 300 folks that have signed on today to be a part of our panel. So let me take a look at the questions that we've got coming through. So can you say just a little bit more about how, what's included in sort of this expansion related to behavioral health? I know that there's a collaborative care component, and then there's a whole lot of codes that really relate to tobacco and addiction and the like. So just talk through a little bit of that, and what's the percentage increase, and what was motivating CMS to move in this direction?
Sure. No, thank you. And so for the specific behavioral services that have had substantive increases, and to be candid, behavioral services directly are some of the most, have seen some of the highest increases of any service in the fee schedule this year. The first is around tobacco cessation services, so screening, brief intervention, referral for treatment, or what they call SBIRT. And so for tobacco and for other substances, we're increasing the value of that service by about 20%. And
Was this a service that was not readily billed? People were not necessarily billing the service?
And part of it is to say, well, that additional step that we were talking about earlier, I'm going to find this additional code and add it on to the visit.
Yeah.
And we,
administratively complex.
Yes.
Yeah.
And so this one we didn't change from an add-on code. We kept it as an add-on code. But we just thought, we'd heard from groups of researchers and other stakeholders that said that, really, it is just that this is not like in the interest of the individual, and they might as well just bill pure E&M. And so we think it's important enough of a service. It's aligned to the work of evidence-based lifestyle change and lifestyle medicine that we wanted to actually like call it out. So tobacco, other substances are included pretty substantially, and so about a 20% increase. We also acknowledge that there are a few things in the fee schedule that have a stronger evidence base in terms of than the collaborative care model, and we've heard consistently for years that we're undervaluing that service and not allowing the intent of the business model that was established by the AIM Center at the University of Washington and has such like rigorous evidence behind it. And so we're making a substantive between 20 and 40% increase in those services, and that's going to be, we think that's going to be what's required even in some of these more virtual first environments to deliver the collaborative care model, and so that's a pretty substantive change as well. So behavioral health, we are recognizing, acknowledging, aligning to the Secretary's agenda to make America healthy again, that like we need to be aggressively funding these services. Just acknowledging the evidence that's there, and it was great conversations with researchers and other advocates in the field over the last year. We'll double click that we really want people to bring evidence to us, bring us empiric data, help us make these decisions, and that's always going to be what we're going to find most compelling.
Super. Well, that is very helpful explanation, and I think we embrace that, and it really does put us on a path towards addressing people's medical and behavioral health needs. So thank you for that. Just a shout out on the empiric data. Many states have ABCDs, and they've got these databases. And so, we hope that folks will take a look at what Doug Jacobs has led in Maryland. He wrote a piece in Health Affairs, and consider themselves if they want to examine their own state claims databases and assess where there might be overvalued codes. I mean, I think that's very, very helpful for CMS, and helpful input as they think about moving forward. And is that the only, did you get any other empiric data as a part of this call for empiric data?
The first year results were a little limited.
Okay.
The MHCC team is great, and so Doug Jacobs, Andres Chappelle, and others. And so we did also receive some suggestions about some revaluation of what they called the Harvard codes. And so those were long-standing services that are typically for services that actually haven't changed much over the last 20 years. So the best
Harvard codes, only very smart people build those codes.
So it's CMS shorthand for codes that haven't changed since the original valuation in 1992. So what they're trying to say is that these services need another look, and so it's a fair point. It's appreciated by a legal group in town, but we are really interested in these underlying analyses. Again, great team at the state of Maryland. We're really excited to see if other APCDs pick this up.
Right. Well, I understand that the average length of time for when a code is revalued is 17 years. So a lot can change in that period. And so I think that's really important, and we appreciate that you are doing some of that look-back work to understand whether or not, there's been more efficiencies, and then to address those efficiencies. Okay, you touched on, but we haven't really had a conversation about, a lot of the virtual and digital tools that are now coming into primary care. And the adoption has been really fast, and I think we're all trying to understand. I mean, ambient scribing is off to the races. A lot of excitement about that. Now also some lawsuits in California from some consumers concerned about, what happens to my data. So, there's a lot of positives, but then I think there's also some concerns about, there's some concerns about patient privacy and the like. But I would love to hear, how you all are approaching this and, what you anticipate for the future in terms of how this might affect payment.
It's a great question. If we think about the underlying statutory authority Congress gives us to set the physician fee schedule prices, it comes down to the time and resource intensity. And so it's a fascinating question right now if I can use open evidence and it expands my scope of practice.
And you're doing that now in practice?
And I do it every Friday. It's a great tool. It's really remarkable. It's described as magical by some academic researchers. And so so the core to clinical practice is you're asking and answering clinical questions for yourself. So you're wondering. So
do you find yourself not consulting with specialists as much because of open evidence, or not really?
So I think in my case, I practice in the safety net, and so specialty access is a challenge in general. And there has been some really interesting early work in e-consults that has established that it's a little more specialty access, but for us it's a lifeline. And I think if I were still able to, if I had better access specialists, I was an integrated system like Inova or others, that I probably would still refer less. It's allowing me to practice much more independently, which I'm loving. And I think it also, the question of how, it'll be very interesting to see, because about half docs are using open evidence at this point. So that's one great example of, you could describe as clinical decision support tools. The ambient AI tools that sort of help with the documentation burden, I will also say have been as transformative in my own practice. And I am consistently impressed with the ability, the summarization from, we use Suno at the Mary Center, and so there's many different tools. They're very, very helpful. They reduce that kind of pajama time that we all talk about as clinicians. And so when you think about sort of the way that it's already transformed practice, it's incredibly exciting. And in terms of what does that mean for the underlying service valuation, it's a really difficult question to answer, and a big part of this very lengthy request for information. And so the other thing that I think is very interesting is since I've been like in medical training, there's always been patients are coming to me with this WebMD service, and so they're trying to understand, like, what they Googled it, they read about it, and the question of how these digital tools are going to more substantially change that front door to primary care. And if a chatbot has my brain, or even a better clinician than myself's brain, then we really want to think about what does it mean for primary care services in general, and where and how we should be supporting additional tools. And what I mean to say is, if a patient's coming to me and they've spent a long time on ChatGPT Health, understanding their underlying medical condition, that may make things faster. But it's certainly not going to replace primary care docs. It's just a question of how is it going to expand the patient's availability of evidence-based health information. So lots to say there. I think you're finding this administration to be quite interested in artificial intelligence in general, and I think it's one of the most compelling questions in Washington right now about how that'll be handled. But I think there's going to be no real replacing of primary care docs.
Well, we're happy to hear that, and we don't think patients want that either. I think, the evidence shows that the relationship is critical to achieving the outcomes that primary care can achieve. So we understand that, bots are going to be a part of the team, and I think that's really important to help support primary care, but we think that relationship is critical. Now, probably the primary care clinician's job is going to change. I think the patient is going to have a lot more information than they did previously. Hopefully, that information will be evidence-based and appropriate to their condition. That's a whole other conversation. But clearly, there's a lot in this arena to work through, and we want to help you. I know the community wants to help you shape that going forward. So, let's talk about kids for a minute, because we've really been talking about Medicare payments, but, we know that the fee schedule is used by all payers. So, Medicaid keys off of the fee schedule, so do commercial payers. Let's talk about what are the implications of the changes in the fee schedule, do you think, for those that are getting their care through Medicaid, and including in your answer, children, and how do you think this may affect the commercial payers?
It's a big question, and it's one that in particular has some valence to primary care, but also let's just address that there's a proposal this year for a important Medicaid and service that certainly impacts kids, where maternity codes this year are expected to unbundle. And so we propose doing so in not exactly alignment with the recommendations that came from the AMA, but recognizing that since the beginning of the fee schedule, maternity services have been paid from prenatal, intranatal, and through delivery as one bundle. And so as part of establishing better information to address the maternal mortality crisis in this country, that ACOG and others had recommended parsing out these services and unbundling them. So there is really important Medicaid work that comes through the fee schedule, because we set those Medicare evaluations that, while we acknowledge there are a few births in the Medicare program, we do think it's important, and very frequently we are establishing coding and payment rates for services and other payers. And, well, shall I say, we're establishing our coding and payment rates, and they're often used by other payers. So maternity services is a really important one this year that's in the fee schedule. Another place, I'll say with regard to pediatrics, in terms of kiddos, we do have a series of pediatric codes that we maintain. We're always interested if those need to change or be updated. We acknowledge there have been substantial changes to Medicaid funding, but we do recognize that if there are updates that we need to make in the actual code set, that's on us. I hope in the future there's more Innovation Center work on the pediatric space as well, but acknowledging that with all of its sometimes challenges, the Medicare program does maintain code sets that serve as the cornerstone of the U.S. healthcare system.
They do, and we did advocate for some changes in the code set that affect pediatrics. Didn't get it this year. We're going to continue to advocate for it. I think this is also the rationale that I explained to those in the employers who are concerned about commercial and our colleagues in Medicaid. Please join us in advocating for these changes to Medicare, because they obviously have an outsized effect on all payers. So it's very important. Okay, here's someone who's been piloting APCM, this individual is acknowledging that cost sharing is a big problem for patients and clinicians. Are there ways, let's see, and when the question from a patient comes in about what services will this add? So, patients are really confused. They may be getting a request for a beneficiary copay, and their interaction with the primary care clinician that month was a portal message.
Right.
Are there ways CMS can help clinicians message about APCM or normalize it as how we now value primary care?
So I think that the acronym, the name of the services, they can all be pretty confusing. The additional codes that our patients are required to pay copays for can certainly be challenges. I think from our perspective, and this is in part to systems, in part to individual practices, there are areas where CMS is quite concerned with regard to the underlying like fraud, waste, and abuse potential within the Medicare program. I'll highlight two big areas that are important, and then we'll jump into APCM. The first is to say within RPM and RTM, so remote therapeutic monitoring and remote physiologic monitoring, we observed an explosion in these services over the last year. We are quite concerned after our experiences with skin subs about rapidly increasing utilization of services. And so when it comes to RPM and RTM, we are making pretty substantial changes this year and recommending that these services fundamentally are integrated within the clinical team. Now, when it comes to the areas where we're not concerned about fraud, waste, and abuse, when you have an established relationship with your clinician, there's been the initiating visit, you're in a longitudinal relationship, there's monthly payments that are supporting that. We acknowledge, I'll just say that APCM has some clunkiness in terms of the way that's been implemented these ways. They can be confusing for folks, but this is not where we're turning. We're encouraging health systems to consider directly supporting APCM to help with that. So we're concerned about RPM, RTM. We're not concerned about APCM. We want to encourage it. But part of these questions are why we want to reconsider the overall primary care, what I'll say is potential bundle or prospective payment. And so it's these sorts of implementation challenges are why we're asking those questions. If I have a minute, I'll mention one other important area that's less on the primary care radar, but just it's going to be a hot button topic this fall. We are proposing, in addition to all of our other changes, this will impact primary care somewhat orthogonally. Right now, the Medicare program pays for zero-day globals, simple same-day procedures, and we allow for there to be an evaluation management built on the same day. We say it must be separate or significant and separately identifiable in the zero-day global, and you add a modifier 25 on for that service. We actually are already paying for visits in the zero-day global, and so we're revisiting this long-standing practice and saying, we think they're actually maybe double paying, and we need to apply what we'll call our long-standing practice of the multiple procedure payment reduction, or MPPR. So we're proposing paying for the cheaper of the two services by 50% less, because there's so much of the time and resource cost that's shared if it happens on the same day. This is going to be a topic of considerable attention, but we recognize that if we're already have visits priced into the zero-day global, Medicare really needs to know what we're getting, what we're paying for.
Yeah. Well, we're already hearing about some of the, some of the concerns, and I think in particular for rural patients who travel far, and when they get to the destination of being able to get care, they are looking to get these multiple services. So, but I also understand your perspective. So, trying to figure that out, and then of course the globals. I mean, that's a whole other issue that we've been talking about for some time, and there's been research on. So, there's a lot there to tackle for sure. For sure. Let's see. This is just a very straightforward question. I love your response to it. Why make primary care use a modifier? Why can't CMS just pay the higher rate?
So for this year, we're proposing this modifier. Again, it's proposed to be finalized in November, we hope, but we need public comment to drive that. The longer answer to that question is, again, it's a long primary care RFI. The first section includes a question of we have, on a long-standing basis, we've been paid for primary care services through those outpatient evaluation management and care management services. We could also differentiate within those evaluation management services, and so we're asking questions about should there be essentially a primary care evaluation management, an acute care evaluation management, and a consult. And we could differentiate the actual service, or like this person saying, pay primary care a little bit more. So more to come. Yeah, yeah. Well,
This has been an incredible conversation, and as you can see, Jake is very knowledgeable. You've helped to provide leadership to a large and comprehensive and broad set of proposed changes. We're going to look forward to working with our community to respond RFI related to primary care and to the primary care parts of the rule. And please stick around. We're going to now
Sure.
have a conversation with some very important leaders across our membership and get their reaction, and then take questions from our audience. So without further ado, let me introduce our panel. First up is Aisha Pittman. Many know Aisha. She's SVP of Government Affairs at the National Association of ACOs, and she leads the organization's advocacy on thought leadership efforts, advancing policies that accelerate the adoption of value-based care, and highlighting the importance of provider-led transformation. Welcome, Aisha. Great to see you. Stephanie Quinn, up next, SVP of External Affairs and Practice Experience at the American Academy of Family Physicians. She oversees the AAFP's divisions of Government Relations, Practice Advancement, Strategic Engagements, and the Robert Graham Center. God, I didn't realize your job was so big, Stephanie. Welcome. Great to have you. And last but not least, Dr. Nima Sheath. She's the Vice President of Health Justice at the National Partnership for Women and Families. Lovely to have you here, Nima. She leads the organization's portfolio on maternal health, reproductive rights, and health system transformation to improve health outcomes and reduce disparities for all women and families nationally. And Nima is a psychiatrist. So it's lovely to have you all here today to unpack this rule further, probably answer some of the questions I didn't get a chance to. So many fabulous questions came in. Let me start with you, Nima. What did you hear from Jake's overview and your reading of the rule that's most meaningful to the 34 million women, their families, and caregivers that are getting care either directly or indirectly through their family members through Medicare, that you found most exciting?
Absolutely. Thank you, Anne, and thank you for the invitation to be here. It's really exciting. What an incredible conversation to be part of. First, let me say, I think what resonated most with us was CMS's recognition that whole person primary care must include behavioral health, not just as a psychiatrist, but looking at how important behavioral health is overall. The proposed increases in reimbursement for collaborative care, behavioral health integration are a really important signal that, integrating mental health in primary care is a priority and that this is the path forward. These models have such strong evidence for improving these really common and unfortunately increasing, conditions of depression, anxiety, but even trauma disorders, lots of complex behavioral health conditions that are now also being addressed by collaborative care. And, for the more than 66 million Medicare beneficiaries, about 34 million of those are women, right? And that's increasingly meaningful, knowing that women are more profoundly impacted by these chronic diseases, and what an impact behavioral health has on healthy aging, functional status, menopause, quality of life, caregiving, right? And how crucial it is to caregiving. So I think this is really important. Lastly, I'll say that we're thrilled to see the proposed expansion of beneficiary cost sharing. We are a consumer organization. We know that high cost of healthcare is such a burden to families and children, and women in particular. And we know, for example, research shows that 1 in 5 beneficiaries report delaying or skipping needed healthcare because of that cost. More than 1 in 5 say that healthcare costs made it harder for them to afford food and utility bills. And again, noting that overlay of women are in more caregiving roles with this burden. And 1 in 6 over age 65 report problems paying their medical bills. So we're really excited to see these changes. I think that's what stands out for us the most.
Thank you. A really important set of proposed changes. Appreciate that. Stephanie, primary care practices, including family physicians, are really at the heart of care in communities. And despite undervaluation that has been longstanding, we've been rallying against that for years together. There's now major hits to patients' coverage and finances from HR1. What do family physicians need from CMS this year and beyond, and really all of primary care clinicians, not just to keep the doors open, but to better connect more Americans to whole person primary care relationships?
Yeah, thank you for the question. This won't surprise you, but 1A is greater investment in primary care. I mean, I think CMS has really kind of gone up to the line in a lot of ways to invest in primary care. But if we don't really infuse the infrastructure with more investment, then we're just entrenching ourselves further in the system. And so, we're seeing that with APCM, and we're also concerned about, the uptake and some of the barriers there. I mean, I think something that we really could count on CMS to do that they've done very well is leaning into the power of convening. I mean, we've seen this in the health tech ecosystem. We saw it with the prior authorization commitments. Traditional Medicare alone is not going to be able to transform the system and really revolutionize the way we resource and deploy primary care. And so if we could get private payers, I mean, Jake even said it himself that Bob Phillips, systems aren't making these investments. They aren't paying for G2211. They aren't using APCM. And so if we can start to get some engagement from private payers to bring some of these innovations along, then you'll start to see, I think we're all starting to row in the same direction. And it's not just on traditional Medicare to try to do that.
Thanks. Yep, agree with you. I mean, we can't just change the form of payment. We have to change the amount, right? Because just looking empirically, we've had a decline in primary care investment since 2012. And as I think anyone who's had any interface with all of our organizations here on the screen and with PCC, we're less than 5 cents on the dollar right now overall. And so we ask primary care to do more, but we're not willing to, we haven't yet heretofore been willing to provide the remuneration to make that possible. And while Medicare is critical, looking over here at Jake, and important for it to be a first mover because of how many lives it can simultaneously touch, it is so important that we have this kind of alignment across all payers because practices deal with multiple payers. And it also, I think every American deserves to have this kind of better integrated, better coordinated, relationship-based kind of primary care. And so everybody needs to move in this direction. And Lordy knows we don't have a healthy population, and primary care is the way we're going to get to a much healthier population. Okay, Aisha. I looked at the statement that you guys put out. We were together right before the rule hit, and we cracked up because Aisha had kept refreshing the CMS website to see when it would be downloaded, and she got a message. Are you a real person or are you a bot? Because you've refreshed so many times. So anyway, Aisha, you guys applauded the significant steps for ACOs in this rule. But what specifically do they need to do, that is the ACOs, this year CMS need to do this year or in future rulemaking to further strengthen primary care in MSSP? And let me just say, we've had a great working relationship to work on exactly this problem. So love to hear your thoughts.
Yeah, thanks. Thanks for having me. I would say we have been calling on the administration to really modernize ACOs in 3 buckets of sustainability, burden reduction, and innovation. I'll touch on 2 of those. And the sustainability piece, shared savings has been one of the few ways to increase investments into primary care over the past decade, and it's been really successful. Where we are now is when you've been in the program a long time, you're competing against your own success, and the benchmark ratchet, it reduces your ability to earn shared savings, which reduces that reinvestment back into primary care. And so we saw some steps within this rule to address some challenges with benchmarks around the trend factors, but we need to go a step further. I think for folks who have been doing this since the pioneer ACO days or the start of the program in 2012, and we're almost 15 years in, you're at a point where it's almost unsustainable to continue. And so that's the place where we want to see more work, but some work was done in this role. I think the other piece that I wanted to touch on was really around innovation. So the beneficiary cost sharing waiver is huge. That has been present in the innovation center models in ACO REACH, and it does increase the types of services that we want to see, things like complex care management, where there is the beneficiary cost sharing is something that prohibits use. So I think that's a huge step. We want to see a lot more innovation. There's been a number of waivers in the innovation center models that have not come over to MSSP. This was the first step. Keep going. And then the other piece that I know we've done a lot of work with PCC on it is around wanting to have stronger primary care capitation options. This really gets to cash flow. So shared savings comes a whole year, a whole 6 to 8 months after the end of the performance year. So it helps you have those upfront investments and wanting to see something that's really flexible. So we do have the ACO PC Flex model that has hybrid payment. That's not the right approach for all practices. And so we do like this approach that has been in reach and is in lead around just having a primary care capitation option where you can meet practices where they are. Some want hybrid payment, some want full capitation. It helps you think about, are groups coming together to share in services like integrated behavioral health, or are they putting it in their own practice? And you can design around that rather than having one approach set by the government. So while it's just an RFI, we're really hopeful. And I was glad to hear Jake say that potentially for next year's rulemaking, we would see that as a permanent option.
Thanks so much. And we know that primary care practices really differ. The population served, who's on the team, their payer mix, and that's one of the fabulous benefits of primary care. It really is responsive to the environment in which they're living, but it's also a complicating factor. And so it does mean that I think we need to have a lot of different options so that we meet practices where they are. And I think we have a collective problem that we haven't been able to grow the most successful value-based care program in the entire country, which is, ACOs, and in particular primary care ACOs. We've been flatlined. And so glad that you all are thinking about ways that we can further incent the formation of ACOs and get more, we're focused on getting more primary care into ACOs. And I'm sure we'll be sending you even more ideas, Jake, about how to do that. I've got a question for all three of you, but I did want to hit the pause button and see, because you all are, I'm sure you've had thoughts about what all of your colleagues say, and just see if you wanted to follow up on anything that any of your colleagues said, or else I'll just go to the next question.
I would just add quickly, it came up briefly with Jake. We're so appreciative about the primary care exception being proposed. This is something we've pushed for a long time that really has to do with how residents are trained. And so this is going to not only extend the opportunities for them to be exposed to, higher levels and without supervision. I mean, I think some of it just didn't make sense from a workflow or a training perspective. So we're going to see a lot of meaningful action there. And I think that's another place where we would like to see some of that extended through health systems so that they can really optimize their workflow.
Stephanie, can you unpack that a little bit more?
Yeah, so there used to be a requirement that residents could only see patients, if we're talking about the 5 levels of E&M visits from 99211 to 99213. Well, we know that a lot of the population are in those higher codes, and that is actually what they will be seeing in practice. And not being able to see those as a third-year resident without supervision just didn't make sense. And so even just from a workflow perspective, having to have a supervising physician come oversee that visit when they're fully equipped to do these things, and you want them to feel fully equipped to do these things, knowing that they're constantly in touch. So we were really pleased to see that that's something that they've proposed for this year. We think it's not only going to translate into more meaningful training, and that really starts to reflect what they're going to be seeing in practice and build that confidence and competence. It also, from a workflow perspective, is going to ease some of the training pressures that a lot of our faculty members are under.
Super. And actually, that was one of the questions that came up. So you have just answered it. That is very, very helpful. Okay, for all of you, I think
Sorry, Anne, I
we.
want to add.
Oh yeah, please go ahead.
And
Nina.
one thing,
Sorry.
I just really appreciate your point, Stephanie. I just can't. I worked in a collaborative care setting at a FQHC in DC, and you're so right. It was a complete workflow issue. The residents couldn't see those cases on their own. So I just really appreciate your point and want to build on that and support that plus one. And I just want to add that, in terms of your question for me and in terms of what stood out, I also want to take a minute to talk about some of the pieces that are still missing, maybe, and that we want to work towards, which
Sure.
is, um, how do we ensure that the behavioral health investments that we're seeing are going to fully align with CMS's broader vision around hybrid payment, right? And because it's such a positive shift, whole person health, keeping that sustained. So how do we look at kind of the sustainability piece of this step and that ensuring that the behavioral health piece is not just kind of an add-on, but it's really sustained. And then we're looking at social drivers, because for us as a consumer advocacy org, we're always looking at the caregiver engagement, team-based care coordination, the ability for folks to actually be fully involved and part of that decision making. So I just think that that's something to add is a sustainability piece of this as we go forward.
Yeah, it's a really, really good point. And these are not one shots, right? They've got to be built on over time, and we've got to double the primary care investment and more in order to get to those robust teams that really can provide the full spectrum of services and connect patients to community-based services to address the social drivers and the like. No, we're not done. We certainly are not done. These are all steps, and appreciate the response from this rule. But I think we're going to keep pushing and underscoring how urgent it is to move quickly, because the foundation of our healthcare system is not as strong as it needs to be, and the underinvestment is one of the reasons for that. And so that's something that within CMS's purview they can help to address, and other payers out there too. You guys are not off the hook. You're a real part of this whole equation. So I had mentioned, and I really want to applaud Medicare leadership. They have not been balking at bold action, because these are hard things, particularly within a budget neutral construct. But the question that I always ask is our payment system delivering health? We're not getting healthier as a population. And there are many reasons for that. It's not just the payment system, but I think that is a contributor. And we need to think about how we change that payment system. So it really is, this is not about the wars between different professions, but really asking the hard question, is the American population getting healthier? What can we do with how we incent the system to prevent people from getting sick and really restore them to health as quickly as possible. So we've got a detailed 30-page RFI asking about valuing primary care, asking about AI and tech-enabled care, hybrid payment. I'm going to ask you to be reductionist for just a minute. What is the most important message from your perspective that CMS needs to hear about how to move payment reform for primary care forward? Anybody can start. Anyone who's like, I'm ready. You guys are not shy.
I can jump in. I would say first and foremost, the features of primary care that make it so difficult to value are the very reasons why it's so effective. And so as we're looking at revaluing it, looking to center that human relationship. I mean, you kind of alluded to it. Health is more than just a collection of codes. That does not amount health. And I think the true power of primary care is in that longitudinal relationship. And so looking at how to start to begin to assign value. I think because it's been so difficult, that has been left out of a lot of the valuation conversations. But we really have to center that if we're going to get on a different track. And on that point, I think that the AI piece is important because there is the opportunity for that to become just another level of discrete services and create more fragmentation, when really we should see it as something that could facilitate and empower that relationship.
I'll sort of follow along on that because I think we are in a place where we have to rethink what our ultimate goal is. So as a proponent of value-based care, the goal here is one of the tenets was supporting primary care better and managing that longitudinal relationship. So we've done that in some ways. We're limited by the models. What else do we need to invest? And how do you account for things that are new? So to that point, AI, it's adding a cost. It might eventually save costs down the line, but right now it's adding novel therapies, novel drugs, all add costs. And so how do we account for that in the overall healthcare equation? And what does that mean for how we value primary care and value-based care? And what is the right budget to have to pay for care of a person? And what is the risk that we think is appropriate to sit with a practice and that they can control versus what are things that are new or different that need to be paid for elsewhere and not necessarily impact primary care payment?
I can build off of that because mine was really all about accountability, right? We know that the goal is to design payment systems around the positive outcomes we want to achieve, but then how do we ensure that that infrastructure is in place to hold the system accountable for delivering them? And I think we're just short on that accountability piece. And so payment models, improving, really paying for those outcomes, but then paying for the things that we know get us to those outcomes, which is the whole team-based care, integration of behavioral health, strong relationships like the improved rapport with patients and their providers. And then the flexibility with the social drivers and, like you said, Anne, being able to refer to folks in the community. So we're seeing that this is taking us towards greater flexibility, but with that greater flexibility, we do need a greater sense of accountability of ensuring that we're getting there. The last piece I'll say is around equity. Like, how do we have accountability around equity and building equity into this model and making sure that it is addressing the folks that are at the highest of those billing codes, the 215s, the 214s, because they are the most complex. They have the most needs. And how are we doing that equitably and ensuring that we are not, have incentives that are potentially still misaligned. And I'm really happy to see, I should say, that, CMS is exploring how to rebalance payment towards primary care. I think that that's a huge step forward already in that accountability and equity piece, but I think we still have a ways to go.
Yeah, I mean, if people if people can get those services early on, then hopefully that forestalls them from having to get more expensive services down the road, which is very challenging for folks to pay for at all levels, but in particular for low and middle income folks. And then I think the waiving of the beneficiary co-pays. I mean, we'd like to see that for all of primary care and behavioral health because, again, as I mentioned earlier, we want to keep that front door open. The other thing I would say to all payers out there is, it's really important to lead with a lot of urgency in reform of primary care payment and delivery. I mean, right now, value-based care is one of the only solutions we have to addressing the cost conundrum. And if primary care is not robust, it can't deliver the benefits of value-based care. It is absolutely critical that we have that strong foundation because that's really where we are able to prevent those expensive downstream services, and so it is critical. Okay. This is a question that came through for Jake, but you all may want to jump in on this too after we hear from Jake. Jake had talked about a 2-year plan for change for primary care payment within the physician free service. That was tantalizing. Can you give us any hints of what 2028 could bring?
Sure. Thanks so much. Hope the mics turn back on. Really appreciated learning from you all and hearing your reactions writ large, and the call outs around thinking about incorporating behavioral health into the prospective payment, about using our convening authority. And I think it's such a rich conversation. Really grateful for it. I think anytime you see a robust and detailed request for information in the physician fee schedule, it's worth taking note. And so the reason we're spending so much time on it, the reason we're describing this as a reimagination of primary care services, is because we take it so seriously and such a strategic priority. Now, are we recognizing the longstanding relative undervaluation of primary care? Absolutely. Are we thinking through comprehensively from what are the levels of the visit that we should consider, to how should we reconsider care management services, to where does behavioral health fit in, to what are we thinking about for technology and the broader prospective payment options? Absolutely, it's all there, and would really like to engage with PCC members and others in a robust response to comments, and certainly as soon as we're through the comment period, we'll do our level best. Last year we had a government shutdown. We'll do our level best to actually get a summary of all the comments out, and then we want to start working on proposals. Again, we can't guarantee things are going to happen next year. It is our absolute intention to move forward from a request for information to proposals as soon as possible. I think specifically in the rule we called out the prospective payment option for shared savings is moving forward at the earliest possible opportunity, if I got the language right. So this is a priority for us. It remains a priority. We're really, we think it's essential not just for CMS's priorities, but for HS priorities writ large. And how technology is involved, we're going to learn a ton about. So you can blame me if there are too many questions, and we look forward to as many responses as we can get, and then certainly excited to work with you all as we're developing proposals for the future.
Super. Well, thank you. Okay, we've gotten quite a few questions in, some for our panelists, some for Jake, so we're going to kind of go back and forth. A couple related to behavioral health integration. And so first, for those that are not licensed, but that are providing these kinds of services. So, how optimistic are you all that the primary care fee schedules will enhance use of team-based care, community health workers, care coordinators? Do you think that it will help lead practices to start to use peer support specialists? Curious what you think, and then we'll also ask Jake to weigh in.
Happy to hop in since it's behavioral health related.
Yeah.
It's a great question. I mean, I think that we have to recognize that those providers, unfortunately, have not been integrated even before the shift, right? And so there's a limitation in terms of how far this can go. And I'm really curious to hear what you all have to say about this, but we've structurally been lacking the integration of community health workers, peer supports, and the infrastructure for their inclusion is actually deficient beyond payment. It's actually, it's a practice issue, it's a workflow issue, it's a report, it's a trust issue. There's not great even training. I mean, I think SAMHSA, has come out with some peer support training now, but it's a very complicated issue, so I wouldn't answer it with a yes or no. I think it's nuanced, and that I think it's a step in the right direction, and maybe creating some precedents of a model where it could be scaled. But I think we have a long ways to go there. And I think really we also have to think about, when we're thinking about those types of providers, how do we bring that care into the community? Because really the evidence shows that bringing community health workers, cultural brokers, peer support workers, navigators to the community where patients are is actually more effective than being in a clinical setting. So I think there's a lot there to think about that I don't know if I'm answering the question, but I think I'm adding nuance to the things that we need to think about there.
I would second that. So I think in ACOs and accountable care is the one place where we are seeing a huge focus on team-based care and there's integrated behavioral health and more partnerships with the community as well. But it's still a struggle. We still have a long way to go, and we're not constrained by the payment mechanism. This is where folks are investing their shared savings frequently. And so they're still taking their steps, but this is an area where NACOS does a lot of shared learning because it's still really difficult, and we're challenged by things like workforce challenges. And so I agree with Nemo's point of step in the right direction, but there's a whole lot more work to be done.
Yeah, and the only thing I would add, because I completely agree with both of you, is that there's a data piece that I think works hand in glove with the success of any payment changes, that you really have to have a data infrastructure in place. And I know with some of these allied health professionals, those systems don't talk, and where you're collecting information that's very important to a clinical encounter, those systems are not connected. And so, I think getting the payment right and the resources and being able to connect with these clinicians and allied health workers is very important. We can't overlook that there are some critical data pieces that would need to be addressed, and interoperability as well.
And bi-directional, right? So if you're referring out, you're going to get information back, and it has to be integrated and coordinated and all of that, and we're a long ways from there. Jake, anything to add?
Sure. Just in terms of the core question of whether moving to more team-based care and prospective payment would establish like better behavioral integration, it sure should.
Yeah, it should.
So we hope so. And so as we've been establishing our questions and thinking this through, we really do align to the NASM 2020 report on implementing high-quality primary care and those three interlocking teams that are so important to us. And so, so I really hope so. Or else we're making some mistakes. And then, in terms of the specific call out around peer support specialists, my memory is only so deep, but I thought in 2024 we established the BHI integration codes, and those were community health integration and principal illness navigation to be specifically allowable for peer support specialists. Mm-hmm. We tend to struggle with community health workers writ large. Shreya and the impact folks have always said, there's like the community health worker magic that we kind of struggle to establish in licensing and code and payment. And so
hard to get magic into a code.
Right. So we struggle sometimes, but those opportunities really should live within the CHI and PIN codes.
Super. Well, we want health systems to take up APCM, and right now I think we've had some challenges doing that, and I think we need to think about how do we get them on board. In Maryland, apparently, gosh, Maryland's getting a lot of acclaim here on today's webinar. The Primary Care Commission at the state recommended that APCM be a mandatory offering by private payers with no cost sharing. Wow. Does CMS work with states to understand APCM implementation and other primary care payment reforms?
Sure, great question. We know that our innovation center colleagues have spent quite a long time in earlier total cost of care models in Maryland, and now as they're rolling out the Maryland Ahead approach, this may be part of that. I'm not entirely sure. We do have deep partnerships and relationships across states, and so there's certainly this administration's effort in rural health transformation work, and then our Medicaid colleagues are quite close with many of the states. We consider, from an innovation center perspective, the states as units of transformation, just like our primary care practices and ACOs. And so the deepest relationships are probably there at CMCS and CMI, but we're certainly engaged and curious, like if Maryland can be a test bed for the rest of the nation, as they have been so many times before.
Well, I mean, I think it is not only for states, but for commercial payers to think about, mimicking APCM, asking their health plan counterparts to make that a part of the benefit offering. So, we don't want to just keep this in Medicare. As Stephanie said earlier, we need this sort of alignment across all payers. Okay. Let's now kind of a question about G2211. We know Sure. You're proposing to make some changes here, but in the first few years, as frequently, if not more frequently, it's been the subspecialists billing for G2211. Will any of these proposals help to address that issue? Because I think G2211 was something that was really intended for that longitudinal relationship that mostly is primary care, although not exclusively. We recognize that. You think any of these proposed changes will address that issue?
The proposals are quiet on the point of whether you're serving as that focal point for all services or for one longitudinal condition. And there was, in the initial build of G2211, there was that both primary care and specialty care call out, establishing the opportunity for both. We've not made changes there yet. I will say that, again, sorry for all the questions, one of our questions in our RFI is asking, well, what should that entail? If you're responsible for a patient's serious health condition and you build G2211, shouldn't you also be responsible for all their preventive health needs? And so basically, based on Ashani Ganguly's work, and we know that, and our own internal analysis agrees, that there's substantive billing for G2211 through many subspecialists, and to a large degree, that's okay. We know that nephrologists for CKD4 and ESRD patients are the principal managers of their care. Many patients, Medicare patients, consider their cardiologist to be their closest relationship. And if you're interested in billing this service, we do also expect you to be ensuring they're getting all of their other health needs met. And so that's one of our questions in the RFI this year, and we'll think about where we go for next year. And just to say, there's certainly a propensity for urologists to be billing the service, and they're probably the ones that we need to think the hardest about, how they're exactly meeting those patients' preventive health needs, and be they lifestyle modification, risk factor reduction. I think urologists can be some of the principal clinicians for men's health and individuals with principally men's health needs, but we also need to make sure that they're providing that holistic care that the code's intended to provide.
I'll just jump in here quickly
Yeah.
and also say that appreciate the increased payment for clinicians in ACOs. We know that incentives work. We've had 9 years of an advanced APM incentive, and clinicians in ACOs receive a higher conversion factor update, and those things have led to greater adoption of accountable care. And so I think seeing this piece and recognizing the additional work that clinicians and ACOs are putting in, we really appreciate that. And I do think when in the ACO model being held accountable for total cost of care, you really think about who's billing for which code and who's going to get that increased payment, because not everyone can do it, because then you're going to fail to meet your benchmark. So I think something to watch for is how are clinicians and ACOs leveraging that code, and that'll tell us a lot about who's most appropriate to bill for it.
Yeah, well, that sounds like a great research study, comparator, right, between what's happening in fee-for-service with this code and what's happening in ACOs with this code. Okay, let's see. We're getting close on time. There's a couple of other questions that I think are coming in, and then we'll wrap up. This is a question probably first for you to lead off, Jake, and then I'd be interested if others have a point of view on this. Sometimes people think, well, maybe we should just have a different fee schedule for primary care. That's not, so you kind of take it outside of this budget neutrality question. That would obviously be a question for Congress. How would that interface with the work that you do? Is that something that you've discussed at CMS? Curious what all of you think about this. Is primary care that distinct from the rest of the specialists that it would warrant that?
It's a fascinating question. And in general, this is certainly like something that we're leaving up to Congress, and I think that there are two things to say on it. First, just to say that we know that there's special call-outs in statute for anesthesiologists and radiologists, and that's worthwhile to consider in terms of why that's occurred and sort of how it's managed in the statute. The other thing to say is that in general, we know that primary care is so pervasive in primary, and so this is such a broadly utilized set of services, and so that's usually, if there's not going to be a budget neutrality adjustment, it's usually for very smaller boutique services that are uncommon, and we certainly want primary care to be common, and so I think we're principally going to have to leave it up to Congress to take that action.
And Congress is beginning to move in that direction. I don't know, Stephanie, if you want to describe the Dr. Caucus bill that's been introduced, or your reflections.
Yeah, I won't go into great detail, but I think what it gets at are some of the underlying structural challenges with Medicare with the Medicare fee schedule. And I think budget neutrality is really the root cause of a lot of these issues and the distortion that can be caused when you're taking money from one part of the fee schedule and shifting it over here, and creating this zero-sum game. I think primary care has obviously, that has what has put downward pressure and passive devaluation over time. And so you do need to get to inflationary updates. You do need to get to ways that the costs that Medicare is paying represent the actual costs of the services. And so, I mean, in primary care especially, I would say that budget neutrality has been terrible for getting needed investment in primary care. And so, we're very encouraged by the conversations around how do we get underneath some of these structural things. And, because it's not just the core dollars in. Of course, we need that. We'll always ask for that. We're not shy about asking for it. But you have to also address some of these, the structural payment levers in the fee schedule. And so, we're very supportive and encouraged by the fact that Congress is actually doing the hard thing, and it's not just what's in front of their face at the time. It's a more forward-looking approach, and so we've appreciated the engagement and dialogue with them on this.
Well, I'm sure you all would love to jump in on this question as well, but we are at time, and thankfully we have an opportunity to continue this conversation. We're going to be working together to respond to the draft rule and to the RFIs. The organizations around our virtual table will be doing their own comments as well. We think there's going to be a lot of synergy between what PCC is putting forward and what you all are. You will also have lots of other new and important ideas. But I think we're encouraged by the broad set of proposals that are here. We do really feel that you all are responding to many of the things that we've been advocating for over the last number of years, and we're encouraged by what Congress is doing as well. So this is, primary care is not in the strongest position. We are seeing some very, very hopeful signs on the horizon, and we are moving forward. This is what patients want. They want more time with their primary care clinicians. This is what everyone in this country wants, to be healthier, and primary care is a key solution to making that happen. Please send the webinar around when it comes out to colleagues who couldn't make it. Take our survey, and very much appreciate our panelists, Aisha, Stephanie, Nima, and Jake, for joining us today. You guys have been terrific. You're such important leaders, and it's just a delight to partner with you and move primary care forward. So thanks so much, and have a great afternoon.